Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined by Alex Slutz, our VP of Marketing and Public Relations, as well as Dr. Francesco Rotatori, our Chair of the Cardiovascular Department, and Dan Ryan. He is the Senior Advertising and Marketing Director here at the Staten Island Advance. Welcome. Through RUMC Connections, you will meet the fantastic doctors, nurses, medical professionals, and partners that make our hospital thrive. On our show, we will also provide you with useful information about maintaining your own health and hopefully get you answers to some of your own medical questions. And we could not have a more perfect guest for our show today. February is American Heart Month, and according to the Centers for Disease Control and Prevention, heart disease is the leading cause of death for men and women in the United States, with one person dying every 34 seconds from cardiovascular disease. Here on Staten Island, studies show that approximately 27% of Staten Island adults have high blood pressure and or high cholesterol. While this is slightly lower than the nation overall, Staten Island still has a higher rate of death due to heart disease than the rest of the nation. So as I mentioned, today we're joined by our Chair of Cardiovascular Department, Dr. Francesco Rotatori. Welcome.
Thank you.
Dr. Rotatori graduated from medical school at the University of Milan in Italy. He followed up his education with postgraduate training at the Centro Cardiologico Monsino, and it's a prestigious medical center in Milan that specializes in cardiovascular disease. He later attended the Sinai Downstate College of Medicine. Dr. Rotatori cares for patients at RUMC that are suffering congestive heart failure, arterial fibrillation, coronary artery disease, heart attacks, hypertension, and more. So thank you for joining us today.
Thank you for having me.
And of course, as someone on the front lines of patient care, what are you seeing when it comes to cardiovascular disease? Are you seeing more cases than usual, or are we doing a good job as a society in managing our heart health?
Well, first of all, I'm very happy to be here. Thank you for having me. Starting from the numbers that you brought up, the first answer would be we're actually not really doing a good job. It appears as still cardiovascular disease is a big problem. The numbers are daunting. There's a lot of disease out there, and the recent events of the pandemic or so have brought up the fact that numbers even got worse for some reason. Now, we're going to go into details of that a little more, but cardiovascular disease is it's a big problem, and in terms of the fact that it involves so many aspects of our life, and it goes from lifestyle to diet to genetics to basic family history to the way our genetic setup is made. And the bottom line is that we haven't found a way to prevent this disease as good as we have found for other type of diseases. There are screening tests for cancer that are very well known, very well used, mammogram, colonoscopy, and this. For cardiology, we haven't found a good way to prevent this disease. And so I have to say we became very, very good in fixing the problem once we find it. But the big task in the cardiology field is really to prevent the disease. And this is going to be, it has been in the past few years, and it's going to be a collaborative effort that has to start from the doctors, of course, and research, but also has to go through the society and changing in a lot of aspects of our lifestyle.
Okay. So what would you say are some of the risk factors or the symptoms for cardiovascular disease?
Well, of course, we have to do a little bit of explanation here. What we talk about heart disease, and we're talking about a lot of different things. Mm-hmm. So, of course, the heart is this wonderful, amazing organ in our chest that pumps blood to all the systems in our body. It's a very simple organ at the end of the day. I mean, it's just a muscle that pumps on a rate of 60 to 100 beats per minute. And there's a claim that you're born with a certain amount of heartbeat, and so you try to protect your heart, don't use it too much, and it's going to stay good. Problem is that as a muscle, it requires blood supply itself to work. And so if you develop blockages in the arteries that provide blood supply to the heart, then the heart will start to have problem in terms of you can lose part of your heart muscle if an artery closes down. or you can have symptoms of chest pain just because every time your heart is required to do some type of work, some type of extra work, then that blockage in the artery makes the muscle suffer. Same way that your muscle in your legs, they can suffer when you run and you're not capable to do it. Same way the heart is sending you signals and saying, say, I can't do this. I mean, I don't have enough blood supply. This is what we call angina or angina. Don't call me on the accent. And that is one of the most typical symptoms of heart disease, and in particular of coronary artery disease. And when we say coronary artery disease, we mean the arteries that are surrounding the heart and that provide blood supply to the heart muscle. Of course, this is one of the problems, but then there is also other problems when we talk about heart disease. For instance, you might have been familiar with hearing the words of congestive heart failure, or you maybe have someone that has heart failure. Heart failure basically again means that the heart is failing, the heart is not working. And sometimes it's not working because of what I already said. Some other times instead it's not working for other reasons. Cardiomyopathy is the big word that we bring out. It means that in some cases the heart muscle itself is diseased, and which means that the heart muscle, the cells in the heart, they lose their ability to contract. And that can be, again, genetic or can be due to some other disease. Diabetes can cause that, or sometimes even infection. And here we open the big discussion about what COVID brought us. And so cardiomyopathy sometimes can happen even without having blockages in the arteries. In that case, then we have medication, we have advanced treatment, and so other things. So this is one other type of disease that, and how the heart failure comes. Also, not to mention also that the heart failure can also come when the valves in the heart are not working. I was talking about the muscle. There's also at least four important valves in the heart. And if, because of genetics, because of infection, because of other reasons, the valves are not working anymore, that's also a reason why you can have heart failure. And all this said, there is another section of what we do, which is what we call electrophysiology. What it means is that the heart as a muscle works, but to work needs an electrical system, a very, very fine electrical system that is inside the heart, almost like electrical wires, that they control the contraction of the different chambers of the heart to make them contract in a synchronized fashion so that the heart pump works. You can imagine, you have one chamber, then the other, one chamber, then the other. You can't have the opposite, the blood is going to go the other way. So, of course, there is this very fine electrical system that can have disease. You can have disease like the upper chamber of the heart may lose their electrical ability, and you end up having atrial fibrillation. Some people might be very familiar with this term. Or so the heart might have, the electrical system might not work enough, and you end up needing a pacemaker, which is a device that helps when the heart is too slow. Or sometimes instead the heart can go crazy fast. So in that case, you need a defibrillator, which is another device that helps when the heart goes too fast. So multitude of issues, they go under the big umbrella of heart disease. So it's I just wanted to give a little bit of a background of what we're discussing, and that's what it is. So of course, the symptoms, as I said, they can go from the chest pain of one to the shortness of breath when the heart is failing. If the heart is failing, it's like when you're running and you start being winded. Imagine that when a heart is failing, it's like a constant run. I mean, you're short of breath because your heart is not capable to work. So shortness of breath, chest pain. But then sometimes, because the heart the heart is pumping blood to other organs, and if it doesn't bring enough blood to the brain, then you have symptoms of like passing out, feeling dizzy. And so a lot of symptoms can go under the umbrella of heart disease.
So you mentioned COVID several times. What are you seeing as a cardiologist in terms of COVID's impact on the organ itself? And also, we're coming out of the pandemic, and a lot of people reverted to a sedentary type of lifestyle, which many doctors are saying has brought about its own set of issues with people not keeping up on their health. What do you see in terms of cardiology?
Yeah, that's a very good question, Alex. You got to the point. There's two main issues with COVID. One is that since the very beginning of the pandemic, we noticed that this virus, differently from most of the viruses that we known before, they had a particular ability to affect the heart, directly affect the heart. So we saw a number of cardiomyopathies, as I mentioned before, these numbers. I mean, disease of the heart muscle directly caused by the virus. And so virus affect directly the heart, even in acute settings. But also now there is a growing evidence on the fact that even a year after, even a mild COVID infection, there is an increased chance of other cardiovascular problems, probably because of that initial infection with COVID. And I will go into details of that in a little while. But before that, I wanted to also say that there is a huge other problem that came out with the pandemic, which is what you were mentioning. The fact that during this time, staying home and because we have to be distant from each other, so change our lifestyle. And believe it or not, physical exercise, even the one that we don't notice we do, like walking to work, be with Staten Island, we have a lot of people moving to Manhattan. And when I ask them what they do now when we go to work, there is the subway, there is the ferry, there is the stairs, there's a lot of physical activity that they do. And that has been canceled, wiped out for a year and a half or so. And that caused what we generally call deconditioning. What it means is that your body, as amazing our body is, that can get used to run marathons, at the same way our body gets used not to do anything. So if your body gets used not to do the things that you usually do, once you go back and do it again, it's very, very difficult. And so we're seeing a lot of patients coming to our office saying, I feel short of breath. And the reality is that the COVID-15, the 15-pound weight gain that everybody got after course, but also the lack of activity has caused a decrease in our overall ability to do the function of every day. That itself is an issue, but also we do know that physical activity is one of the best drugs that we have to prevent cardiovascular disease. If you look at the American Heart Association website, it will tell you that if you are physically active, you're reducing 30% chance of a heart attack in your lifetime. If you're physically active, you reduce up to 50% chances of a stroke in your lifetime. So I don't know how many medication as good as physical activity we have in our hands. So that part has been taken off during the pandemic has played a big role in increasing the cardiovascular disease after the pandemic.
And we're not talking about, when we say physical activity, we're not talking about going down and running a marathon. We're talking just general physical activity.
Exactly. Because when you look at the American Heart Association website, it will tell you 30 to 45 minutes of physical activity, even mild activity, which means you were walking. And again, that probably was the commute of our Staten Island. That has played a huge role from a health standpoint, and we have to reverse that. Then, of course, it crumbles down. But with weight gain, we increase insulin resistance, so we increase the chance of diabetes. We increase the blood pressure. And so all this are considered risk factors, as you asked me at the beginning, risk factor for heart disease. And so this was unfortunately the recipe for disaster, because we end up now having to basically restart a little bit from scratch, from where we got before, and re-educate our patients in the fact that a healthy lifestyle starts with a good active lifestyle, and that is a big problem.
Do you see some of the problems that you addressed being significantly greater in Staten Island as a borough?
Compared to the United States, I would say Staten Island, I mean, it's very similar to the rest of the United States. There are some few issues that they've been addressed in lately, but still they play a role in principle in cardiovascular disease. For instance, smoking rates in Staten Island are much higher than anybody else and everywhere else in New York. Obesity, and those are all factors that are playing a significant role in our borough. At the end of the day, the reality is that the way our society is made, and Staten Island, of course, is part of it, is made in such a way that there is a lack of education in what is considered a good lifestyle. And that has to do a lot with diet and what we eat, and partially has to do also with other habits, like smoking, as I said, and physical activity. So the answer is Is that island different from everywhere else? Is not different. Maybe maybe a little worse in some aspect, maybe a little better in some others. Of course, there is a big need in addressing these issues in Staten Island, particularly.
If someone was listening to this and they say maybe I should get checked, could you walk us through how you evaluate a person's cardiovascular health?
Yes, of course. So if someone said, "Oh, you should get checked," the answer is yes, especially once you hit a certain age, after 40, 45, and especially if you have family history, if you have somebody else in the family that has disease, then you should get checked. That's for sure. Now, getting checked, again, as I said at the beginning, is I wish we had the perfect screening tool and that we could use and say, okay, if you do this test, if it's negative, you're good. If it's not, we don't have that, but we are arming ourselves with a lot of tools lately, and there's a lot of things that are probably going to come up in the next few years that are going to help us understanding better the disease. I can just drive it through very simply what happened when you go and see a cardiologist. The first time when you come and see a cardiologist, they say, "Hey, I want to know if I'm okay." Like, so like almost like I'm bringing my car to this. Is that everything okay? I wish I could go in and check everything. I really can't. But what I can do is, first of all, we start with simple EKG, electrocardiogram. And again, as I mentioned before, what the electrocardiogram does, it measures the electrical activity of the heart. As I explained before, we have this electrical system in the heart. If the electrical system looks perfect, that's the first good sign. If the electrical system has some problem, that maybe can raise some little flags. Of course, the electrical system can be tested in stressful condition. That's where the stress test come into place. So a lot of people, we order for them a stress test, which means basically we make you walk fast on a treadmill while wearing the wires for the EKG. And we see if the EKG has some changes during the exercise. And because again, as I said, once I put the heart to stress, when I make the heart work harder, if there is a problem, then the problem might not be present. The rest, it might come up when we do stress. Now, of course, with years, the stress test that has also has other tools that we can add on. I might have heard of what we call like nuclear stress test. The nuclear stress test basically means that while we're getting the EKG, while you're exercising on the treadmill, we also inject in the body a radioactive tracer that emits S-ray and has the ability basically to, after the test is done, you go under a camera, we take pictures, and it lights up the heart based on blood supply. What it means is that if your heart has good blood supply, we're going to see this image of the whole heart, very nice and bright, with no problem. If instead some of the area of the heart don't receive enough blood supply, so don't receive enough this tracer, this area is going to be a little shady, and that will suggest the suspect that there is a blockage in one of the arteries. Another part, actually the first part of this whole conversation, is taking a good history. And in fact, we know that if you have heart disease, in a good portion of time, you do have symptoms. And so if we do find symptoms, sometimes tests don't help. But if we do find symptoms that are suspicious, then we have to go all the way and do some further invasive testing to find out what the problem is.
So when you find that a patient comes in, we want people to, everyone wants to go in, but I came out with a clean bill of health. But somebody finds out, hey, you have cardiovascular disease. What is the next step in terms of treatment, procedures? How do you address this person that they have to deal with until they've had cardiovascular disease?
Of course. So, I wish we could find the disease before it has caused. I wish every time we could find the disease before it caused any damage, before in the very early stages. And in that case, if we find the disease in the early stage, what we have to do is basically aggressively treat the risk factor. We don't yell at people, and it's not that aggressive. It doesn't mean yell, but some people might need that in a good way. But what we do is that we look at the risk factors, which somehow I kind of touched in the discussion, but I mean like high blood pressure, high cholesterol, diabetes, and then again, sedentary lifestyle, obesity. And we tackle all these problems, and we try to be as careful as we are in fixing them. Smoking, vaping. So all these things, they have to be addressed, because I can say, listen, I saw that the disease is starting, and it's a progressive disease. Linearly, it's going to increase. It might not give problem right now. It's surely going to give problem 5-10 years from now. So the patient comes in that stage of the disease, then it's what we call the risk factor modification. And it starts a very important, which I consider very important part of my job. I start the personal relationship with the patient. I involve other people in the care that can be closer, nutritionist, and sometimes also lifestyle coach, and to basically address the risk factors. There are other times in which instead, when we find the disease has already caused significant problem, and so in that case, then we have to document the problem and then take the correct measures. So that's where another part of my job is, which is basically we bring the patient to the cardiac cath lab. So basically we go and visualize directly the arteries in the heart, and we visualize the artery by using X-ray machine and contrast, iodine contrast, and we visualize the arteries and we see if there is a blockage. Now, of course, if there is one blockage, few blockages, sometimes during the same procedure, we're also going to be able to fix the problem by threading a wire through the artery, bring a balloon, which is this little balloon that is squashed over this wire, and then inflate it where the blockage is. And by inflating the balloon from the inside of the artery, we're able to open up the blockage. Now, that wouldn't last too long, so we also put a stent, which is it's a metallic cylinder that is over a balloon, positioned where the blockage is, inflated, and then when the balloon is deflated, the stent stays in place and stays there for good. Sometimes stents are not enough because there's different blockages, or the location of the blockage is somewhere where the stent cannot go. And so then we go for bypass surgery, which is a major heart surgery, which also had improved in many years. Used to be a very, very difficult procedure. Nowadays, patients are not in and out, but they spend only a few days in the hospital and they go back home. And really, it's a very important and curative test. However, all this said, if we don't address the progression of disease the same way anybody else, these people can have problems in the future unless we tackle the problem.
So the disease itself, you said, it's not isolated. It still cause other problems ultimately. If you're not cautious, you can't just go in and get a one-time quick fix. But it's going to lead to a lifetime of issues.
Of course. So the idea is this. So we have these beautiful arteries when we're born, and from when we're born, due to our lifestyles and due to our genetics, we started depositing some cholesterol in our vessel. Now, why some people have more, why some people have less, somehow we know, or this is part of most of what we're studying right now, trying to figure out exactly who gets more cholesterol deposition, who gets less. But of course, it's diffused. In fact, we have the concept of atherosclerotic burden, how much cholesterol you have all around in your body. And we do the calculation of that in the heart with a test called calcium score. This burden, it's almost like, the way I sometimes explain to my patients is like, imagine you have highways and they're clean, but then, of course, the highways can get some problem here and there, here and there. At one point, the road can break in a specific place and we can fix that place. But I mean, there is some disease, so the road has some problem also down the road, and maybe at one point another place is going to have to need some work done. Now, of course, when you do bypass surgery, it's like you're creating new conduit, so other blockages around, other road work around will not be a problem. But of course, fixing just the one place with a stent and just let the road get diseased, I mean, that's not gonna fix the problem for it. The reality is that our desire is to find a way to reverse the disease. Once there is deposition of cholesterol, someone may ask, well, can I get that cholesterol out of my system? The answer is, as of now, I would say no, but there is a growing evidence that some of the new medication that came out in the market or so, they might slow down, they slow down the progression of disease to the point that they can stop it and maybe also reverse it a little bit, or at least stabilize it to the point that it doesn't really cause any problem.
So I know recently the Staten Island Advance featured a story about the advanced lipid panel test. Could you tell us a little bit about that?
Yes. So exactly, this is exactly what we're discussing here. I'm sure everybody heard about cholesterol as a risk factor. So I have high cholesterol, I take a medication for high cholesterol. And also, you might be familiar with the fact that sometimes the doctor tells you, oh, you have good cholesterol, bad cholesterol, which is kind of confusing. Like if cholesterol is cholesterol, right? So the idea is that the cholesterol is circulating in our blood system, bind to some protein, and also having a particular shape. It can be small, these particles of cholesterol, this drop of fat. They can be small, they can be bigger, and so. And historically, for many, many years, we have subdivided that just in high-density lipoprotein, low-density lipoprotein, HDL, LDL. HDL, good cholesterol, LDL, bad cholesterol. So this to say, if you have bad cholesterol that it's high, good cholesterol is low, your risk is very high, and vice versa. If your high cholesterol, good cholesterol is high, bad cholesterol is low, then you have low risk. The reality is that we're learning that it's much more complex than that. You can have bad cholesterol circulating, but not going into the artery. So now we found a specific protein that predisposes you to a much aggressive deposition of cholesterol in your arteries. That's one of the proteins that is tested in this lipid panel. Okay. Or we learned that the process of depositing cholesterol in the arteries is basically an inflammatory process. What it means is like it's inflammation. And this comes from many studies, many years of studies. Proudly saying started in Italy, but it's a lot of things happening. I want to know that. But anyway, so the fact that if we detect a chronic inflammatory status in your body, if we know that inflammation plays a big role in your body, then that means that probably this disease is more aggressive. So in one of the other tests that we tried in this special panel is a CRP protein, high sensitivity CRP protein. The C-reactive protein, CRP, is a protein that is released when inflammation is happening. So by measuring that protein, we know how much inflammation is going on in the arteries, which of course correlates very linearly with the disease of the arteries. So all these factors, and also then what we in that panel also we know that again high density, low density, but also size of the droplets of fat are important. So we know that if they're small, they tend to go into the artery more. If they're bigger, then less. So with that pattern, we basically trickle down all that we know about what is considered risk factors for you, what is not. So it's very good that we have that in our hand as a tool to what we call the risk stratifying people, to find people at higher risk, and so treat them accordingly, and maybe in the early stage, and also maybe to avoid chronic treatment of people that they will never need it.
So once you go on medication, if you change your lifestyle, if you start living a healthier lifestyle, exercise, and do all the things that you're talking about, could you eventually come off of those medications or some of those treatments? Is there ways to continue your health, or once you're on that path, you're going?
No. So it is a very good question, and of course, you can come off medication. The answer is yes. It's very simple. This medication don't fix the problem. So if you have an infection, you take an antibiotic. It fixes the infection. You stop the antibiotic. End of story. The cholesterol medication, the blood pressure medication, they don't do that. They don't. Oh, I have high blood pressure. I give the medication and it fixes the blood pressure. I stop the medication. It doesn't work that way. Those medications, they lower your blood pressure. High blood pressure, you take the medication, you lower your blood pressure. Now, if you tackle the problem from which that brought you to have high blood pressure, then of course the medication can come out. So for instance, we have like a roughly estimate, we say 10 millimeter of mercury, 10 pounds. So if you are overweight and your blood pressure is 140, 150, and you lose significant amount of weight, your blood pressure come down, I take you off the medication. It's very well done. We did it, and or, so for instance, just talking about high blood pressure. High blood pressure, it's a very common problem. The population is divided into two type of people. It's salt sensitive, salt resistant. And people that are salt sensitive, they tend to accumulate salt and water. And so that raises your blood pressure because the circulating volume goes up. These people, if they have a high salty diet, they will tend to have high blood pressure even early in life. So if you have a diet that is low in salt and you control the good diet, you probably don't need medication, at least until late stages in your life. If instead your diet is completely uncontrolled, high salt, processed food, fast food, and food with high content of salt, you're probably going to need medication early in your life. You have 30s, we have 20s. But again, the answer, can I come off those medications? Yes. There's no such a rule as that. I know sometimes some of my patients tell me, I don't want to start it because they told me if you start it, you never stop. Well, you never stop it because you never tackled the problem of why you started the medication.
It sounds like a lot of the things we can do to protect our heart are actually in our own hands. That's what it sounds like.
It is true. I mean, genetic plays an important role, and it is true. But it's really, there's really two faces of the same problem. One is genetics, that we cannot change, at least as of now. Although a lot of research is going also into trying to see if we can at least have interfere in some of the aspect of genetics. But it's a very complicated field and probably not a client lifestyle. But the other part of it, this big part of it, is our lifestyle. So it is in your hand. It is part of it. Your head, like I'm not part of it. And it is in our hand as people, but also as a doctor. There is a big component on education that we need to work on. A doctor. So in this first visit that I do with my patient, my main role is to educate people what can prevent cardiovascular disease. So seeing a cardiologist earlier in your life, especially if you have risk factor, if you have family history, very important also for that reason. You need to be educated on what to do to protect yourself, to protect your health.
Absolutely. And what particular procedures do you perform at RUMC?
So the procedure that I perform, so it's funny, I mean, we say, just explain to patients that cardiologists are divided into two. I mean, there's the general cardiologists, but the one that they do procedures divided into two. There's the plumbers and the electricians, right? So I am a plumber for the heart. What it means is that I do those procedures that I was mentioning before, threatening the wire into the artery. Most likely, most of the time, 80-90% of the time now, we do it from the wrist. There is a little artery here in the wrist. Introduce a little catheter. Catheter goes up to the heart. Visualize where the blockage is, and then through that catheter, we thread a tiny wire, 0.014 millimeters of diameter. So it's very, very tiny. That wire goes in the artery, and we use it as a rail to bring devices to open up the blockage. Now, the devices, I mean, I can talk for hours. We have very cool gadgets. I mean, but the idea is that this blockages in the arteries can be very complex, can be heavily calcified. So we have devices like a rotoblader that basically is a diamond-shaped tip that basically shaves the calcium from the artery before it positions a stent. Or now we have lithotripsy. We have a device that gives shock waves to the wall of the artery to break down the calcium to make it yield better, to put a stent. But then we put a stent. And this is what I do. Of course, this is done electively when we find problem with stress test or so, or this is done also in emergencies. The heart attack, what is the heart attack that people say, oh, I had a heart attack? Heart attack is when, unfortunately, one of these blockages in the artery, maybe it's not closing the artery completely, maybe even just a little bit of a blockage. For some reason, this plaque of cholesterol breaks, and so the cholesterol is not in the wall of the artery anymore, but it's facing the blood, and that causes a cascade of events in which a clot is forming inside the artery within minutes, within seconds, and the clot forming in the artery closes completely the blood supply to a large area of the heart muscle. That causes the tremendous chest pain, the position of the patient like this, tremendous chest pain. Ambulance comes in, they bring it to the cath, they bring it to the hospital, and what we do, we have a system 24/7 in which we rush the patient to the cath lab and we table. Most of the time, we open the artery and within 90 minutes and restore the blood supply and minimize the effect on the heart attack. So this is what things that I do. The electrophysiologist, the electrician of the heart, is that they deal with the electrical problems. They can basically interfere with those wires that they go a little nuts and they create very fast heart rate, or they can implant pacemakers, the defibrillator that I was saying before, they help for the rhythm of heart.
Which advanced procedures would you then refer out to Mount Sinai, who we're affiliated with?
Okay, so of course, Mount Sinai is our affiliated institution for a higher level of procedure. As I said before, sometimes there are too many blockages, and so we can't put stent. The patient require bypass surgery. That's done at Mount Sinai. We don't have CT surgery for bypass in our hospital, so patient gets transferred out for that. Also, I mentioned earlier, the valves in the heart can get diseased, and when there is disease of these valves, the valves needs to be changed basically, and there's a change of the valve. We can do a full evaluation. We can prepare the patient. But the change of the valve that up until a few years ago was done exclusively by CT surgery, basically opening the chest, taking the valve out, put a new one. Now it can be done from the inside, from the groin, and so that all that we don't do in our hospital and we transfer out.
Okay.
But how is that relationship that basically covers the whole gamut of cardio services between Mount Sinai and RUMC?
Yes. At this point, we have everything that is needed for overall cardiovascular care is provided by this combination of, but these two combined programs. Most of it we do it here. The higher level is done at Mount Sinai. Also, there are situations in which we are dealing with a very, very sick patient that they come to our hospital. We can stabilize them in our institution and then transfer out for advanced heart failure. There are devices out there to support people where the heart is basically not working anymore as a trigger to transplant or so. And that everything is done, of course, in a tertiary center like Mount Sinai. However, everything starts from us. We do have Impella device, which is it's an amazing device that we can implant, and we do it in our hospital from the groin up to the heart. And this device is basically sucking blood from the ventricle and pushing in the aorta, basically doing the work of the heart while the heart is not working. So we do have this in our hands, and so the combination becomes really an outstanding cardiology program, I have to say.
Well, I'd like to thank you, Dr. Rotatori, for joining us today. Thank you for all that you do for us and keeping us safe and healthy.
Thank you. Thank you.
Absolutely. And in closing, if you have heard, we employ highly skilled, experienced board-certified physicians that can serve you at our state-of-the-art facilities in Staten Island. If you'd like to contact our cardiovascular department for an appointment or to learn more about our services, you can call us at 718-818-7425 or visit our website at rumcsi.org. And speaking of running, like we were chatting with you about, on Saturday, April 1st, RUMC will host its annual Arnold Obey 5K. It is a run or a walk, so you're welcome to join us. It benefits our Wayne Sena Neonatal Intensive Care Unit. The event will be held at Clove Lakes Park, and if you'd like to register, you can do so by visiting rumcsi.org/5K. RUMC's Wayne Sena Neonatal Intensive Care Unit has a survival rate of over 99%, which is actually one of the highest rates in the nation. And your support is needed so we can continue to save young lives and keep families together. So if you can, we'd love for you to sign up, participate, and join. One other event that you can look forward to is May 22nd. RUMC will host its annual Jack Sip golf, tennis, and bocce outing at Richmond County Country Club. For more information and to reserve your tee time, court time, and dinner tickets, please visit rumcsi.org/golf or call 718-818-2106. That about does it for this episode of RUMC Connections. Thank you for joining us. I'm Meredith Gaskins.